We'll be moving to next part of today's program. And next is the college lecture. This month's college lecture is by Dr. Dhananjani Seneviratna, MBBS Peradeniya, MD Colombo, MRCP UK, Fellow of FCCP. She is presently the consultant cardiologist, District General Hospital, Kegol, and she's an interventional cardiologist as well as competes in cardiac imaging and clinical cardiology. She has undergone her training in National Hospital Sri Lanka as well as Worcestershire Acute Hospital, Worcester, United Kingdom. Over to you, Dhananjani, for your presentation.
Good afternoon. Thank you for the kind introduction. First of all, I would like to thank CCP for inviting me to deliver this lecture. I thought to discuss about pulmonary embolism today. Pulmonary embolism is a condition obstructing the pulmonary arteries by a material. Most commonly, it is a thrombus. It should be generated elsewhere in the body. Commonly, it is generated in the deep veins of the lower limbs. My presentation today mainly focus about the thrombus-generated pulmonary embolism, but it could be air, tumor, or fat causing the pulmonary embolism. With the obstruction of the pulmonary arteries, there could be reduction of circulation to the relevant lung segment. Then it will cause the ventilation and perfusion mismatch leading to hypoxemia. On top of that, with the obstruction of the pulmonary arteries by the mechanical obstruction with the thrombus will cause and hypoxic vasoconstriction and reduction of arterial compliance due to hypoxemia will lead to sudden increase of pulmonary pressure causing high pulmonary hypertension. This will lead to acute pressure overload of the right ventricle. This, at the end, right ventricle will go for the failure. Right ventricular failure is the most critical determinant of the severity and the outcome of the pulmonary embolism and primary cause of death. And it is again rapidly progressive. As this spiral showing, it is a vicious cycle. Reduction of right ventricular output will lead to reduction of left ventricular preload. Then it will cause reduction of left ventricular, mainly cardiac output, leading to reduction of coronary perfusion. Again, it will cause more hypoxia to the right ventricle. So it will act as a vicious cycle. There are several predisposing factors to cause pulmonary embolism or deep vein thrombosis. They are very much important because depending on these background risk factors, we decide the probability to have the condition. This will be important when we lay down the investigation plan. Other than that, the chronicity of the risk factors will decide the recurrence rate, and again, it will lead to the decision about it will alter the decision about the duration of anticoagulation. If it is a chronic risk factor, anticoagulation should be long-term or lifelong. There are three categories of risk factors as mentioned here. It could be strong or intermediate or weak. When it comes to diagnosis, early, very high index of suspicion is very much important because there's no specific sign or symptom for pulmonary embolism. Patient will come with the background risk factors and clinical symptoms like dyspnea, chest pain, pre-syncope or syncope, hemoptysis, hemodynamic instability or tachycardia, or patient may be asymptomatic. Then with chest, when patient come with the chest pain, it could be pleuritic if it is a distal embolization, but it could be typical angina due to right ventricular ischemia due to central pulmonary embolism. So here, differential diagnosis are acute coronary syndrome and aortic dissection. We should clearly exclude them. Then, as I mentioned, when we are going to investigate the patient, we have to check the probability of having the pulmonary embolism or DVT. This should be done with the good clinical judgment and some prediction rules. They are mentioned. They are calculated with the previously mentioned risk factors. So Geneva clinical prediction and Wells score is widely used. We can calculate, give the numbers and calculate it, and we can decide whether the patients have low probability, intermediate or high, or pulmonary embolism is likely or unlikely. When we are going to investigate the patient, chest X-ray, ECG are simple tests and they are widely available. Chest X-ray, rarely we can see the wedge-shaped infarction, though it is not specific. Chest X-ray is very much important to exclude the possible differential diagnosis like pneumonia, pneumothorax, you can see. Additionally, when the patient comes with significant hypoxia and difficulty in breathing, if the chest X-ray is normal, we have to suspect pulmonary embolism and at least to exclude. In ECG, most commonly it will be shown as tachycardia. Sinus tachycardia is the most commonly found, but atrial arrhythmias are common arrhythmias. Among them, atrial fibrillation is the commonest arrhythmia to have. When the patient comes with the unexplained atrial fibrillation, then again we have to think about possibility of pulmonary embolism. Other than that, the peculiar features like S1, Q3, T3, as shown in the ECG, is not much common, but at the same time, it is not that rare. We have to look for it. There could be right bundle branch block or right ventricular strain pattern in the ECGs. D-dimer, it will be elevated with acute thrombosis. So if it is negative, we can happily exclude the possibility of thrombus in the body. So it got good negative predictive value. But if it is positive, we can't diagnose with the D-dimer only because there's, as you all know, several conditions like cancer, infection, inflammatory conditions, and pregnancy and other several conditions can cause positive D-dimers. Nowadays, CTPA, computed tomographic pulmonary angiography, is the diagnostic tool to diagnose the pulmonary embolism. As picture mentioned showing, there could be thrombus in the films. In multi-detector CTPA, we can visualize up to subsegmental level. It got good specificity and sensitivity, but the radiation exposure is the problem. In ventilation perfusion scan, we can see a perfusion defect in the relevant lung segment. This got low radiation and low contrast, but not much specific like CTPA, but good in patients with pregnancy or contrast-induced anaphylaxis or severe renal failure. And it is not much widely available also. Then pulmonary angiography, it is also now rarely doing because of the CT. We can see the filling defects. It should be proven in two directions to prove that something there inside the pulmonary vasculation. Echocardiography, it is the widely available test and it can be available bedside. So we can see right ventricular dilatation and right ventricular failure in the echocardiogram. But the problem is negative echo won't exclude the possibility of pulmonary embolism. The good side is we can differentiate some differential diagnosis which are mimicking the pulmonary embolism. They are pericardial tamponade, acute valvular dysfunction, left ventricular dysfunction, aortic dissection and hypovolemia, we can happily exclude with the echocardiogram then and there. So these are very much important differential diagnosis. In DVT scan, 70% of pulmonary embolism patients will show the positive DVT scan. Good thing is, if it is positive, it warrants anticoagulation. For example, when the patient, if a pregnant patient coming with the possibility of pulmonary embolism, and when the DVT is positive, we can go for directly the anticoagulation if the patient is in the low risk category. When it is combined with the echo, it increases the specificity. So this is the summary, which is when we suspect the hemodynamically unstable pulmonary embolism, that is a high-risk pulmonary embolism, we can do the bedside echo and look for the right ventricular dysfunction. If there's no right ventricular dysfunction to cause hemodynamic instability, we should think about possible other causes as well. If it is there, we can go for CTPA to prove the pulmonary embolism. When the patient is hemodynamically stable, then we are using our clinical judgment and prediction rules to assess the probability of the pulmonary embolism. When the patient have a low probability, we can do the D-dimer test to exclude it. If it is positive, again, we have to go for the CTPA. And patients with high clinical probability, we can straight away go for CTPA to diagnose the condition. Diagnosis only is not adequate here because itself it carried a very high risk of mortality. So we have to assess the severity of the pulmonary embolism. Obviously, when the patient is hemodynamically unstable with the pulmonary embolism, they are going to the high risk category with worse prognosis. When the patient is hemodynamically stable, again we have to check whether patient's risk level. So here, features of right ventricular dysfunction is very much important. It could be clinical or imaging or lab parameters, as it is the major determinant of the outcome. Other than the right ventricular dysfunction, some comorbidity and some associating aggravating factors also decide the prognosis. Clinically, there will be tachycardia, hypotension, respiratory insufficiency, or syncope in the history. These points highlighting the presence of right ventricular failure. So we should be vigilant. In echo, as I mentioned, right ventricle may be dilated, right ventricular dysfunction may be there, and thrombus, if you're lucky, you can see a thrombus in the right ventricle or pulmonary arteries. Additionally, if there's a coexisting patent foramen ovale, there will be reversal of shunt because due to right-sided pressure overload. Actually, this will cause severe hypoxemia in the systemic circulation and will increase the systemic thromboembolism because of the shunting from right to left. Hemodynamically compromised patient, we can do the bedside 2D echo to check these features of right ventricular failure and dysfunction, dilatation. And when there's a CTPA is not available, we can justify the reperfusion treatment with the available echo findings because it carries a very high risk of mortality. In CTPA also, it will show the right ventricular dilatation. It's an indirect marker of right ventricular dysfunction. Actually, it should be dilated more than the left ventricle in the CTPA. Then lab markers also helpful to check the right ventricular dysfunction. Mainly high sensitivity troponin and hard type fatty acid binding protein. These two will show the myocardial injury. If it is positive, it may say there's worse prognosis. But if it is negative, actually negative predictive value is very high in these two to give the information of good prognosis. Then markers like pro-BNP or NT-pro-BNP, these markers will be elevated with the heart failure. So it can use here. If it is elevated, again worse prognosis. If it is negative or low levels, implies good prognosis. Other than that, we can use lactate, serum creatinine, neutrophil galactinase, hyponatremia, and vasopressin. These are markers of tissue hypoperfusion. So it will, when they are elevated, it implies the poor prognosis. Actually, we can combine all these clinical parameters, imaging, lab parameters, and hemodynamic status of the patient to give the prognosis. For example, imaging showing their right ventricular dysfunction with high troponin in the lab test indicates poor prognosis. Then we have to vigilantly follow this patient up for thrombolysis. Then, as I mentioned, several aggravating conditions and comorbid factors also can lead to the poor prognosis. It is assessed in the pulmonary embolism severity index. These are the aggravating factors. As in prediction rules, we are giving numbers to them and calculate it, and we can assess the prognosis. When it is high, it carries poor prognosis. Then once diagnosed the patient, we have assessed the severity, then should go for the treatment. In acute phase, emergency management of hypotension and right ventricular failure are important, and thrombin-specific management like anticoagulation and reperfusion or thrombolysis are the special management in pulmonary embolism. In emergency room, we have to correct the hypoxemia with the high flow oxygen. Most important thing is they are at high risk to have anesthesia-induced hypotension. So we should be cautious when we are going to intubate the patient. Then correction of hypoxemia won't be possible most of the time with the major pulmonary embolism unless reperfuse them. In advanced life support, when patient arrested with the possible pulmonary embolism, most common rhythm is non-shockable rhythm, that is pulseless electrical activity. We have to continue the CPR. And at the same time, we should start early reperfusion treatment, that is thrombolysis. Bolus of the thrombolytic agent should be given early as possible, and then CPR should be continued at least 60 to 90% before stopping it. Then right ventricular failure can manage medically with volume loading and vasopressors. Norepinephrine is the preferred vasopressor. Dobutamine also can be combined with it, and ECMO also can be used if it is available. Then come to anticoagulation. When we suspect the patient to have pulmonary embolism with high or intermediate risk category, we have to start anticoagulation promptly before waiting until they confirm the diagnosis. Here, low molecular weight heparin, unfractionated heparin, fondaparinux, or direct oral anticoagulants can be used. Unfractionated heparin can be used if you are going for thrombolysis. If you are planning for it, better to start the unfractionated heparin. Or when the patients have severe renal failure or severe obesity, it is difficult to calculate the dose of the low molecular weight heparin. So it's okay to continue the unfractionated heparin and monitor the APT. Then in long term, we have to combine with the oral anticoagulants. But in acute phase also, direct oral anticoagulants can be started because they got very short onset of action. Warfarin is the drug for long-term anticoagulation. The onset will be take 3 to 5 days, so it should be continued at least 3 to 5 days with the unfractionated heparin to keep the INR 2 to 3. Then INR should be 2 at least for 2 consecutive days to stop the parenteral anticoagulant. Then the pulmonary embolism specific treatment is pharmacological thrombolysis mainly. It carries itself the risk of bleeding. Therefore, we have to weigh the risk and benefit. So, patients with very high risk of high risk pulmonary embolism should promptly go for the thrombolysis. It has faster onset of action, but greatest benefit with the early treatment within 48 hours. When the patient is symptomatic, we can start the treatment even up to 6 to 14 days. Failure rate is around 8%. These are the mainly used pharmacological agent, RTPA and streptokinase. Multiplex is the drug we are using here. It got good thrombin specific action than the streptokinase. So it is preferred. And the point is there are some absolute contraindications for thrombolysis. But when the patient is dying, we can't wait for the contraindication. So we have to weigh the risk and benefit. And for example, recent surgery, then we can thrombolyze them, give the blood transfusion. Like we have to clinically judge the benefit of the thrombolysis. When thrombolysis is failed or contraindicated, we can think about percutaneous catheter-directed treatment. This is not widely available, only available at the cath labs. This will, we can access the pulmonary artery through the inferior vena cava to the right ventricle and to pulmonary artery, put a catheter, and we can aspirate the thrombus or fragment it into small particles to embolize it to more distally. But the main thing is we can combine with the pharmacological thrombolysis. We can start a thrombolytic agent through this catheter directly to the thrombus. Then lower dose of thrombolytic agent is required and the success rate is also very high. There's a place for surgical embolectomy if everything's failed. The cardiopulmonary bypass machine is required. If possible, should combine with the ECMO, and surgically we can remove or suck the thrombus. Then there's a place for vena cava filters. This device is inserted in the inferior vena cava to prevent the proximal thromboembolism. This is used when there's a contraindication for anticoagulation or anticoagulation failed situation or patient with very high risk of venous thromboembolism. Then when we are discuss about the management plan, they talk about multidisciplinary pulmonary embolism teams, that is called PERS. It is emerged in the USA and now increasing the acceptance. Cardiologists, pulmonologists, hematologists, and other professionals are involved here. It enhances the clinical decision making and facilitates the treatment plan. Easy to manage. These are the easy guideline recommendation in the acute phase. So when the patient with acute pulmonary embolism, we should anticoagulate and then should assess the hemodynamic stability. If the patient is hemodynamically unstable, then we can categorize under high-risk patient of pulmonary embolism. Patients, hemodynamically stable patients, we can go for, as I mentioned, clinically and imaging modification modalities, we can assess the evidence of right ventricular failure. If that's so, we can categorize them under intermediate risk. Without anything, only pulmonary embolism is there, they are going under the category of low risk pulmonary embolism. These intermediate risk patients can again categorize with the troponin. If troponin is positive, that intermediate, they are coming under the intermediate high risk patients. These patients should monitor to consider rescue reperfusion if patients deteriorated. Low risk patient actually can manage at the home, especially in the era of the direct oral anticoagulants. Then once sorted the acute condition, we should think about the prevention of the recurrence. As I mentioned, it is depend on the nature of the risk factor. Extended anticoagulation will prevent around 90% benefit in preventing venous thromboembolism, but it got itself the risk of bleeding. So it can be considered only with irreversible risk factors. When the patients having reversible risk factor, we can continue anticoagulation for about 3 months or 6 months. If not, sometimes we consider the indefinite anticoagulation treatment, especially patients with hereditary thrombophilia, recurrent pulmonary embolism, and no risk factors identified with the pulmonary embolism. Then pulmonary embolism and cancer. With the cancer itself, it is a hypercoagulable state causing more risk to have pulmonary embolism. Here, low molecular weight heparin is the drug of choice for anticoagulation. But edoxaban, rivaroxaban can be used, but they are very much expensive. Then treatment should be extended for lifelong or until cancer is cured. Then the bleeding risk related to anticoagulation. Bleeding risk is high in the first month, then it will be declined with the time. There are several risk factors like advanced age, previous bleeding, anemia, active cancer, etc. to cause the bleeding. So we have to keep them on our mind when we are starting the anticoagulation. Then the pregnancy is a common condition to have they are anti-hypercoagulant status causing pulmonary embolism. The problem is they got overlap symptoms. Pregnancy itself can cause dyspnea and dyspnea mainly tachycardia. So it's sometimes difficult to clinically differentiate. D-dimer levels also will be elevated in the pregnancy. So if it is diagnosed, the treatment of choice again, low molecular weight heparin because of the teratogenicity of the other oral drugs. Then long-term sequelae of pulmonary embolism. Most majority of patients will relieve the symptoms after initial phase around 3 months because of the recanalization of the thrombus. But small number of patients will develop the chronic persistent organized thrombus in the pulmonary circulation, leading to persistent symptoms. So patients can be assessed in 6 to 3 months. They think it may be due to muscle deconditioning also. Some predictors are there to have the low persistent symptoms like advanced age, cardiac pulmonary comorbidity, high BMI, smoking, etc. So it can be managed with the efficient follow-up, exercise rehabilitation, treat the comorbidity, and behavioral education and modification of risk factors. Then some patients will develop the chronic pulmonary hypertension secondary to pulmonary embolism. Most of the time, these patients detected incidentally and follow-up patients with acute pulmonary embolism most of the time won't get this condition. So this may be undiagnosed previous pulmonary embolism or patient won't present at the acute stage. So it is very difficult to determine. But the patient, we should assess the background clinical factors and once diagnosed, it should manage with the anticoagulation. Then this is the summary of the follow-up workup of the pulmonary embolism. Once diagnosed, we can manage and discharge the patient with the anticoagulation, and we can assess the patient in 3 to 6 months. If the patient is having persistent dyspnea or when the patient is having risk factors, then we can do a transthoracic echo to check the probability of pulmonary hypertension. They are come under low or intermediate or high. Patients have low probability of pulmonary hypertension, we can discharge them. Then patients with high pulmonary hypertension, we can subject it to VQ scan and refer to the specific centers. Intermediate patients will be again assessed with the NT-proBNP and risk factor assessment to categorize under intermediate group or high risk group. In summary, this is pulmonary embolism is a condition carrying a very high risk of morbidity and mortality, mainly mortality. So, high index of suspicion is very much important to prompt suspicion and prompt diagnosis. At the same time, we should start the early treatment without hesitation and early reperfusion when it is indicated. After the management of the acute phase, we should assess the recurrence possibilities and should lay down the management plan for the recurrence. Thank you.
Thank you very much.
Intensive coverage on pulmonary embolism. Any questions in the audience?
Actually not mentioned, but if we need it, we can do at the catheter combined method. We can do a catheter there and give the thrombolytic, but there's no such a place for half dose thrombolysis.
Right, it's in the guideline.
Yeah, it's not in the guidelines.
And how to find your thrombolytics and anticoagulants? For example, to suspect E, you start preparing on spot. Then you decide thrombolytics.
Yeah, we can do the APTT, and if it is less than 2, we can go ahead.
So if thrombolytics and wait for the APTT and then restart preparing.
Yeah. Because of the risk of bleeding, thrombolytic agent usually OLTPase is having very short half-life. Because of that, we are giving the infusion. So most of the time, it will be okay to start unfractionated heparin after that.
What about enoxaparin?
Enoxaparin also, it's convenient to start because if it is unfractionated heparin, we have to monitor the APTT again. It is very much difficult with our lab settings. So enoxaparin is okay to start once APTT is less than 2.
But you don't monitor APTT when down and enoxaparin.
No, you can't get the action of enoxaparin with the APTT. So
suppose if you are given enoxaparin and then you start from
you
give the next dosing 12 hours, so you monitor.
Yes, we can monitor. There's no monitoring thing for enoxaparin. Actually, it is action will be there for 12 hours. So we can start next dose in the 12 hours time.
Thank you very much for that
certificate of appreciation. Thank you very much for being here today.